So one of the things that both the Surviving Sepsis Guidelines and the HAPVAP Guidelines from 2016 mentioned in their text is they alluded to risk factors to help folks predict multi-drug resistant gram-negative isolates. And so there are many different risk factors in the literature. Location of acquisition, primary source of the infection, but really the two things that we have found at our local center and has been popping up in multiple different observational cohorts are focusing on antimicrobial history and microbiological history. So for the first one, antimicrobial history, I think particularly HAPVAP guidelines, they did a very clear job of demonstrating that prior IV antibiotics in the last 90 days is going to be a relevant and important risk factor, and that helps stratify when you want to use empiric combination therapy for patients. So that was wonderful. However, I did make this point in my talk at SIDP. I think we can do so much more than just a simple yes or no answer of checking, did someone get an antibiotic in the last 3 months? And so, for instance, there's plenty of data to support that the recency of the exposure. Was it 2 weeks ago or was it, 76 days ago? That's going to be different. Obviously, the more recent, the higher the risk of resistance. Duration of the exposure. Was this 3 days of piperacillin tazobactam or was this 3 weeks of piperacillin tazobactam? Obviously, again, the longer the exposure, the higher the risk of resistance with the current index infection. And so on it goes. So I think I was trying to empower folks that are trying to customize their algorithms and risk factors to look and kind of flesh out the details and nuances of prior antimicrobial history. So that's that one. I wish that they had done that a little bit more. They have it in there, but you kind of have to dig. The other part was looking at microbiological history. They do mention that patients that have a history of colonization or prior infection with multi-drug resistant gram-negatives are going to be at higher risk for those same MDR gram-negatives with the current infection. However, they don't necessarily give any pointers or any strong recommendations one way or the other for how to incorporate that into algorithms. I can understand that. It's a national guideline. However, one of the things that I focused on, and again, I gave my call out to the audience, I said, we can do better. So we can and should be incorporating risk of ESBLs or colonization with ESBLs in the last 12 months. That should definitely be something that folks are looking for if and when they're determining empiric gram-negative antimicrobial coverage. And that's just one example. But for instance, in our local center, in South Carolina, we would include if they have any ESBLs, if they have any carbapenem-resistant gram-negative isolates, if they have a history of Pseudomonas, and so on and so forth. Colonization or infection within the last 12 months is very relevant for us. We don't even know if it goes back even further than that. It might be 2 years, 3 years, 5 years. But trying to get a picture of that patient's specific microbial flora is really helpful in predicting resistance. So altogether, the microbiology and the antimicrobial history will go a long way to doing that.